I went to the doctor for a regular checkup in September, and after blood tests I got there, the PSA was elevated a full point from the year before.
Prostate cancer is the second most common form of cancer among men. But new approaches to the treatment of this problem are helping control the disease. Fighting prostate cancer next on St. Barnabas Healthcare Today. Many men, especially as they get older, suffer from prostate cancer or other conditions of the prostate. I'm Steve Adubato. On today's program, we'll talk with three distinguished physicians from the St. Barnabas Healthcare System about prostate health. But first, producer Paula Levine highlights some of the newest approaches in the treatment of prostate cancer.
This year in America, nearly 200,000 men will be diagnosed with prostate cancer. If detected early, it's curable. But knowing where to turn and what treatment to choose can be difficult. 76-year-old Frank Stout first knew something was wrong after visiting his primary care physician.
Well, the only reason I knew was when I went for my 6-month checkup to my regular doctor. He checked my PSA and he said it was rather high, that I should go see my urologist.
Craig Duda was diagnosed at the age of 56 after a biopsy showed a small tumor on his prostate.
My first reaction was, of course, shock, and luckily they told me that it was caught early.
A diagnosis of cancer can be a shock, but both Craig and Frank were helped by the expertise and compassion of the doctors of the St. Barnabas Healthcare System.
When we first see men, we use 3 factors to help decide what is their prognosis and the best treatment for them. We use their PSA level, we use what's called the Gleason score, which comes from the biopsy, and we use what we call the T stage, which is based on exam and imaging studies.
Because of Frank's age and Gleason score, hormone therapy and radiation were recommended. The radiation was delivered using IMRT, or intensity modulated radiation therapy.
Okay, I'm going to raise the table up now.
It's the latest computer-driven technology to give pinpoint radiation to a specific part of the body. And it's the technology we use to treat prostate cancer so that we can give high doses of radiation to the prostate to offer the best chance of cure, but at the same time minimize how much radiation is going to the bladder or the rectum so we can minimize side effects.
Hi, Mr. Stout. Good morning. How are you doing today?
Good morning, Dr. Iyer.
Please.
When I first met Dr. Iyer, I was very impressed with his manner and the way he told me what I was going to go through and what it entails and everything. And he just made it seem so much better.
Okay, we're going to start your treatment now. Hold still.
This reassurance was comforting, especially since Frank's treatment was a long one.
It was 8.5 weeks every day, Monday through Friday, for approximately 45 minutes. And after the first few treatments, I knew what to expect. I mean, there was no surprises. And it was a piece of cake, really.
Because Craig had a slow-growing cancer, he had more options to choose from. Watchful waiting, seed implants, hormone treatments, regular surgery, and the latest minimally invasive surgery with the Da Vinci robotic system.
When they described it, and I read some stuff about it, it was the recovery time seemed to be so much quicker and less evasive and less blood loss. That it was a new technology, but I really didn't have any problem with making that choice to do that.
For his surgeon, using this state-of-the-art robot also had its advantages.
The precision is excellent with the scale-down motion and the visualization. The best part about of the Da Vinci system is the way the instruments are moved. With laparoscopy, it's very difficult to move instruments because it's counterintuitive. With the Da Vinci setup, when you have the joysticks in front of you, you're able to use them the way you naturally would with open surgery. So any movement you make gets translated with the software onto the inside in the same fashion.
Craig went home the day after the surgery, and a week later, he was given the go-ahead to do whatever he felt up to.
So I took, I think, another week off, and then 3 weeks later I went skiing in Vermont for a weekend.
But the biggest worry for most men, whether they have surgery or radiation, are the possible side effects, like impotence and incontinence.
With external radiation therapy, there's a very, very low rate of incontinence, less than 1%. Impotence is something that has been studied in both surgery and external radiation therapy patients. And the studies have indicated that about 65 to 70% of patients who are potent before external radiation therapy can maintain their potency after external beam radiation therapy is completed.
Well, the way they explained the surgery to me was that it's so precise that the nerve damage is minimal, and that turned out to be true.
Frank felt so good during his treatments that he was able to go hunting and fishing. And 18 months later, he's still feeling good.
Very, very grateful. I was very grateful to them. They're like family.
Craig's doctors recommended that he get a blood test every 3 months. And so far, they've been happy with the results.
I feel great. I'm back in a treadmill 35 minutes, like 5 days a week, doing some weightlifting. I skied every weekend from the last weekend in January till the first weekend in April. So, yeah, I feel pretty good.
Great story. Joining us to talk more about prostate cancer and prostate health are Dr. Patrick Ciccone, the director of the Urology Division at Claramas Medical Center. Next, Dr. Domenico Savati, you saw him in the tape piece, a surgeon specializing in urology at Newark Beth Israel Medical Center. And finally, Dr. Andrew Zablo, the vice chairman of radiation oncology at St. Barnabas Medical Center. Gentlemen, I want to thank you for joining us. And I have to tell you, you've got Craig here, who's 56, and Frank, I believe, is in his mid-70s, if I'm not mistaken. Two very different stories, but Dr. Ciccone, the things that happened to them, their prognosis. I mean, Craig is out there skiing 3 weeks after. Frank's fishing, doing all sorts of things. 10, 15 years ago, maybe not the case.
Not at all. The evolution of medicine, the evolution of the treatment of prostate cancer has really gone at warp speed within the last few years with the evolution of laparoscopic surgery, robotic surgery, brachytherapy, and some of the more high image intensity X-ray therapies. It's
not around 10 years ago.
Not around 10 years.
Well, let me ask you, this whole Da Vinci thing that we see over here, there are a lot of people watching right now who say, we like Da Vinci. Is it named after Da Vinci? Where does the name come from?
Well, the robot actually was originally made from the military, and the military had technology to try to perform robotic surgery on the field. The problem with this unit was it's just too heavy, and the ultimate goal originally to put it on the back of a Humvee and possibly do surgery just wasn't realized. So it was sold to the private company, Intuitive Surgical, and they basically thought of a good name for it, and it really fits the system. It's really something that's kind of ahead of its time, and really compared to anything else that I've ever done laparoscopically, it really has tons of advantages that you really wouldn't think would be possible. It really made leaps and bounds over the visualization, over the control of these instruments, over really what you can do on the inside with just little incisions.
Well, it's funny. You can go all the way to today and talk about these advances, But, Doctor, let's start at the beginning, okay? Who gets prostate cancer? Who's more prone to prostate problems? Beyond all the technology and the advancements, is there anything we do in our lives, our day-to-day lives, that bring it on? Is it genetic? What's the deal?
Interestingly, and I explain this to a lot of my patients, that if you take the Japanese equivalent of the American male, same age, match up, all these different criteria, the American men get prostate cancer at a pretty significant rate, and the Japanese or the Asian man does not.
Because?
It really comes down to one thing, environmental diet.
Whoa, those are two things. I want to be clear. Is it the environment and the diet, or are you saying diet's part of the environment?
Dieting is part of the environment.
What are we eating that causes us to have a greater proclivity to having prostate cancer? I'm not getting it.
A lot of the experts will tell you that we eat too much dairy products. We eat too many meat, red meat.
Too much?
Too much.
Well, again, there are a lot of people who are saying, I like my red meat, but I eat my vegetables, I want to do all the right things. And Dr. Saccone, how much is too much?
I think that fat is the real key here.
Fat is the key?
Fat is the key. As a matter of fact, there's been several recent studies that are coming out having to do with the statin drugs that we would take, for example, like Lipitor or Zocor, to lower our cholesterol. I think there's going to be a good body of data that's going to be coming out very shortly showing that patients on those drugs have a lesser incidence of prostate cancer.
So what is it that those drugs are doing?
We think it has to do with the fat and lowering fat, because the key model in any diet regimen to reduce prostate cancer is to lower the fat.
That's the key.
Cholesterol-lowering drugs.
Cholesterol-lowering drugs. Right. Well, I go back to the question I asked earlier. Are there certain people at certain ages in certain ethnic groups that are more prone? Is that a fact or is it a myth?
Well, sure. Your Afro-Americans have probably the higher incidence of prostate cancer, at least in this country.
Because, Dr. Saccone?
We're not actually sure.
We really don't know why.
We really don't know why. It could be genetic in part. It certainly could be diet in part. There's many areas, but we just don't have that pegged down at this point in time.
But when you're talking about Asians, comparable age, right, who don't get prostate cancer, that's got to have something to do with diet, right?
Without a doubt.
Because their diet's dramatically different.
Correct. And it's been shown that when those first-generation people move to the United States, their children who are born in the United States, their incidence of getting prostate cancer becomes exactly the same as us who are native-born Americans.
Because they're here.
Because they're here.
Wow.
They start going to McDonald's, they start going to other fast food places, and their diet changes.
But I want to be clear that you can go to McDonald's and do certain things and eat certain things that won't be a problem for you. It's not McDonald's across the board.
No.
I just want to be clear on that.
Everything we do in moderation. Exactly right. You can go in there and have a...
You can have a salad. You can have chicken without the... You can do a lot of right things there.
You can do the right thing.
Go ahead.
Also, I think genetics does definitely play a role in it. We know that African American do get it at a younger age. They get it more aggressively. And also, if you have a first-degree relative, a father or a brother who's had it at a young age, under 60, there's a very high likelihood that you're going to receive it as well, I think, regardless of your diet. So I think certainly diet plays a big role in that. You can do something about. I think the genetics has to play a role in it as well, and that you can't do anything about. But certainly, if I have family members, if I have patients that have prostate cancer, I let them know. I'll tell your sons, tell your brothers. Certainly they need to get close follow-up, and also the recommendations for PSA screening are at a younger age for gentlemen who have family history of prostate cancer.
Let's talk about this a little bit, the PSA test. Dr. Saccone, we should disclose, full disclosure, we have a relationship outside of the show. We play golf together at a club that has a range of members in terms of age. I'll tell you why I bring it up. I bet you that a lot of the members who play golf there are always asking you about the PSA. I know you're laughing because it's true. I mean, as young as like 30, and I'm sure all the way up, when should I be doing it? Who should be doing it? How often should I be doing it? Oh, come on, I'm too young to do it, right?
Absolutely.
What do you tell them?
Right. Well, you have to almost individualize. I think the American Cancer Association said 50. They should get it yearly. I say 50. However, if, as Dominic says, if there's any family history at all, it should be at a much younger age.
Define much younger. I want to be as specific as possible. Is it 40?
I'd say in 40s, yes. We don't see a lot of prostate cancer in men in their 40s. However, we have seen several patients with it, and it's usually a very malignant disease. And in those patients, you really want to pick it up very early. And so anything that would give you a tip that this person's at risk for prostate cancer, I think you should do a PSA at an earlier age.
Can we actually tell folks what the PSA is? I don't want to assume that everyone knows what it is. What is it, doctor?
The PSA is a measurement that's found in all of our bloodstreams. In males, we have a prostate. It's elaborated by the prostate, and we know that there's certain levels. If it stays within a normal, and the levels change as we age, as long as it stays within a range there and over a period of time. It's not just one specific time period. It's over.
Your test scores over a period of time.
Exactly.
Now
You want to watch
every
the
6
trend.
months, every year?
Well, when it starts out, if you got a guy that's pretty healthy, his prostate feels normal on a digital examination, and his PSA is what we would call in a normal range, you might tell the patient to come back in a year. If he has developed symptoms, now is maybe he's getting some enlargement of his prostate, he's getting up at night to urinate a little bit more. During the day, his stream's getting a little slower, a little more frequent. You test his PSA maybe a little sooner. If you start to see a trend, 6 months is fine.
What's the value there, by the way? What's the value of doing the 6 months as opposed to a year? Is it earlier detection potentially?
It may help you if you're now coordinating with your examination plus what the patient's telling you. My symptoms are starting to change now, or I'm developing symptoms that I didn't have before.
Just those few months can make that much of a difference?
Yeah, I always refer to it as kind of like the straw that breaks the camel's back, where you're just kind of moving along, you're doing fine, and it just takes that little bit of enlargement in the prostate. And it's usually not the cancer that's causing the problem. The cancer is usually very small when we find it. It's the enlargement of the prostate gland that may lead us to start to look for something.
Okay. Let me try this, because there have been some people, Joe Torre, Bob Dole, Rudy Giuliani, right? Sure. Very high-profile people, all of whom have been very courageous and very upfront. To what degree has these guys, right, going out front, not trying to hide it, talking about it, what impact has it had on other guys, other men saying, you know what, even though I was uncomfortable with the idea of it, I was squeamish, I'm doing it because those are tough guys, and I'm a tough guy and I'm doing it. Has it mattered, or am I making too much of that?
No, certainly I think it's mattered some. I think nowadays there's a good push to letting primary care doctors know they need to screen their patients. I think there's still a lot of patients that don't necessarily get the right screening. And any advertisement, any news story, when you hear prostate cancer, a man knows now they're very at high risk of getting it just by being a man. So I think any story like that really does help all men, whether they're high profile or just the average person really think more about their prostate health. Not being as embarrassed to talk about it. I think also
that's all good.
Yeah, I think a lot of the openness about the erection problems. I mean, most guys, if you live long enough, might have erection problems.
Well, you're talking about the concern that guys have that if I have a procedure done dealing with my prostate, it's going to impact on my ability to perform sexually. It is true for some. By the way, what's the number we're talking about? Let's play the numbers game. Percentage-wise, do we know, Pat?
It depends on the treatment, Steve.
Oh, it does?
Yes. In other words,
the radiation.
Yeah. Every treatment has a different side effect with respect to sexual function. Open surgery has one set of numbers. Robotic surgery, another set of numbers. Hormonal therapy, another set of numbers. Radiation therapy in all of its forms, another set of numbers. And this also affects when the impotence comes, if it comes early in the treatment or late in the treatment.
Could it come and then it go away?
Yes, exactly. For example, in individuals who have surgery, most of them immediately after surgery will be impotent for a period of time. That period of time could run from 2 days to 1 year. Whereas, for example, with radiation therapy, that's exactly the reverse. As they're getting their radiation therapy, they will not be impotent. However, as they get scarring a year down the road, impotence starts to become a factor at that point.
All of the treatments that you're talking about are, in fact, available within the St. Barnabas healthcare system. And by the way, folks, as we do the program, you often see the website up on the screen. I'll repeat it a little bit later on. Do yourself a favor, log on, get as much information as you can about the services available within the system. Let me ask this question, because I've been throwing out the term enlarged prostate, and I may have been doing a disservice, and I want to clarify things. Having an enlarged prostate is not the same as having prostate cancer.
Absolutely not.
Well, a lot of people are getting their enlarged prostate dealt with, but for what? If it's not cancer, why would I deal with it?
The enlargement of your prostate is part of the aging process.
Does it hurt?
Sometimes it can when it becomes difficult to urinate. Your prostate can get enlarged sometimes where you may go into urinary retention, requiring some type of surgical intervention.
So people should get out of their minds, if I don't have cancer, I'm fine. Meaning there could be real pain associated with having an enlarged prostate without cancer.
Well, I'll let my two colleagues address that if they see these patients.
If I just give a quick, simple anatomical lesson, really kind of illustrates these points. Basically, the way I tell my patients about the prostate, just think of it as a large donut. Okay, so you have the donut, which is the ring, and that's basically the prostate. Then you have the opening through the ring, which is basically the urinary stream. So the bladder will make the urine, and the bladder is going to push the urine out through the middle of the prostate and then out through the urethra, and so forth. So we're dealing really with multiple issues. One is the location of the cancer, most commonly, is really on the outside of this donut.
Yeah, we're not talking cancer. I don't want to get confused.
I want to, if I can, just kind of explain the whole thing. So it kind of all ties in. So we have the cancer is one issue, kind of is on the shell of the prostate. Now, specifically for your question, the middle part, or the meat of the prostate, is the benign part. Large prostates don't correlate with cancer. So you're 100% right that there's not an association within a large prostate. When you hear enlarged prostate,
nothing to do with cancer.
No, it's really a different process. The majority of the time that the enlargement comes is from benign tissue growing, and which can also grow wide, and you can have a large prostate with not a lot of symptoms, or it can grow on the inside and become tight. So you can have a relatively small prostate and with benign tissue and still have many symptoms. So in general, studies will show that a larger prostate per se doesn't have anything to do with cancer on its own. So you really have to look at two different things.
So it's important that people understand that if they're uncomfortable, Dr. Saccone, and the urinary process, I mean, it's just uncomfortable. That's something that you need to get checked out.
Yeah, see, uncomfortable, Steve, is really an interesting word, because many times there is no discomfort. For example, you take a gentleman who's getting older who gets up at night 2, 3, 4, 5 times. He's not having any discomfort. Or he's urinating every hour. He's really not having any discomfort. But what is that really doing to the quality of his life? He's constantly looking for a urinal, and most of all, you hit it right on the head, his sleep pattern is totally disrupted.
Which has all sorts of impact on his body.
Absolute major impact.
So don't wait for it to be uncomfortable. It may never be, quote-unquote, uncomfortable physiologically, but that's uncomfortable in terms of the way you live your life.
Right. As a matter of fact, you hit on something really interesting. Most men, if you ask them, they come into your office, you say, are you having any difficulty urinating? Said, no, doc, I urinate all the time.
They think that's fine.
They think that's good. But then when you start asking them about it, you say, well, let's go back maybe 10 years or 15 years. Have you always done that? Oh, no, this has just started within the last 3 years. Well, it's getting worse and worse and worse. And you'll have people coming in specifically thinking that's bad, and other people think that's good.
So you have to be asking these questions. You have to do that kind of personal profile for every patient to figure out what makes sense. Now, given the fact that there are all sorts of patients with all sorts of issues, and I know we've touched on this a lot, particularly with the Da Vinci robotic system that we talked about, other treatments that are available within the St. Barnabas healthcare system. Let's name a few and why they're important. Go ahead, doctor.
Well, we have the radiation oncology department. We have several means by which to treat patients with early-stage prostate cancer. We have external beam radiation therapy, where we use
external beam radiation therapy.
Yeah.
Translation?
A large machine that produces high-energy X-rays that we are able to direct and focus into the body to the prostate gland, and we can do it in such a way that we can totally delineate the dose, concentrate it in the prostate gland, while protecting the surrounding normal tissues, which would include your bladder and your rectum. If I go back 10 years, a normal course of treatment would have been 6.5, 7 weeks of treatment with perhaps a 1-week rest because of the side effects associated with it. Now, patients go through 8.5, 9 weeks of treatment, absolutely no side effects. It's rare that I ever have a patient miss a day of work. These guys go to work every day. They're in my department, including their waiting time, no more than about 25 to 30 minutes every day.
Dramatically different. So when we see people like Craig and Frank, who we saw in the mini documentary, again, 20 years difference, 76, 56, out there doing their thing. I mean, go back to the golf thing, seriously. That's quality of life. By the way, whether it's golf or fishing or jogging or walking, it doesn't really matter, or bicycling, right? It doesn't really matter what it is, as long as it's part of your life. There's no real reason, Dr. Saccone, that the vast majority of men who are dealing with prostate health issues, if they were to come into the system and be treated, that the quality of their life should be dramatically hurt on the bad side. It really should be better.
Dramatically better. As a matter of fact, it's interesting in that I think that most people really don't understand that enlargement of the prostate and prostate cancer are two really separately different and distinct things. However, they coexist in probably 95% of the cases.
Coexist meaning if you
they're
have...
together. In other words, as a man ages, a natural progression of aging is to have his prostate enlarged.
Yes.
Okay. Of those men, a certain segment will develop prostate cancer.
What number? Are we talking 95?
No, not 95.
Okay, see, now you confused me there.
95% of men, 90% of men, as they age, will develop prostate enlargement.
Of those who have prostate enlargement?
Of those who have prostate enlargement, a percentage of those will develop prostate cancer. So these two entities really coexist. And as a matter of fact, you were talking about some other therapies to treat the enlargement and the obstruction. Right. We just completed a paper that we just presented down at San Antonio.
A medical paper?
Yes, at the American Urology Society convention. It was Department of Urology in conjunction with Department of Radiation Oncology, where we had men with obstructed prostates who would use a Targus microwave to shrink their prostates so they could urinate fine prior to starting their radiation therapy.
So wait, I want to be clear here. The team approach, again, within St. Barnabas, that you guys interact with each other, your respective areas. You decide that you can shrink it before you get treated in another way, so it's not one treatment or the other. It's this progressive treatment.
Right, it's a team approach.
Which excuse me for interrupting, Pat, which goes in the direction of, are we curing it, by the way?
Oh, I think we certainly are.
Because the word cure, people are uncomfortable throwing around here when you deal with cancer. In a large number of cases, we're curing it.
We are curing cancer, yes.
Not too strong a word.
Absolutely not.
30 seconds left. What have we missed? Doctor, what have we missed?
Just two little things. One about the PSA. Really, everybody wants to know the number. In general, it's 4, but really, for young guys, especially 2.5 is really what you're looking at. If you're in your 40s or 50s and your PSA is over 2.5, you should at least see a urologist and have an expert.
Over
really
2.5.
Yeah, that's my number I would go for young guys.
Real quick on the other one.
Just the robotic surgery and with open surgery. One thing I've noticed with these guys is even guys with bigger prostates, you remove the whole prostate, you cure the cancer, but you also really remove any chance of them developing obstructive symptoms because the whole prostate is removed. So for guys with larger prostates, I think it's something to consider.
Gentlemen, excellent. And I know we helped a lot of people right now, and I want to thank you for that. I want to thank officially our distinguished guest for helping us understand more about the latest developments in the treatment of prostate cancer and also prostate health, the bigger picture. Now, if you want more information about prostate care at the St. Barnabas Healthcare System, please call to see the number on your screen, 1-888-SBHS-123. Write it down. It's really helpful when you do, when you call it 1-888-SBHS-123, or visit the St. Barnabas website at www.stbarnabas.com. For St. Barnabas Healthcare Today, I'm Steve Adubato. Thank you so much for watching.
I think that the reasons for patients to come to this area are, number one, we've been doing this IMRT treatment for longer than anyone else in the Monmouth and Ocean County areas. So we have a lot of experience. Our treatment planning team has a lot of experience. And experience, I think, helps whenever you're trying to produce the best outcomes for patients. The second reason is we have an innovative uro-oncology program here. What that is it's a way for patients to have a multidisciplinary or an approach by many different kinds of physicians so that they can get a rounded opinion on the different ways to treat their cancer.